In case on your end it's morning, it's evening, I'm greeting you. And thank you for making the time to be here with us today. My name is Roseline Chesson, um, and I serve as the Executive Director of Restore Hope Liberia. My academic foundation is in sociology and public health, which means I spend a lot of time thinking about how communities function and how systems interact with them. So my work focuses on how community governance system interact with the formal health system. Not quite recent, sometimes in December. I attended the National Assembly of Chiefs and Traditional Leaders in Liberia, some part in central Liberia called Bon County. And as I sat in that room surrounded by paramount chiefs, clan chiefs, and all of the customary authorities, something became very clear to me. These leaders govern conflict, they shape maternal norms, and they reinforce accountabilities in those communities that they dwell in. So while we often imagine that governance sometimes or all the time, sorry, happens in ministries, let's say the Ministry of Health, I realized that governance is also happening in community spaces every single day. And that raises a serious question that if we are truly committed to building sustainable and equitable health systems, why do we continue to treat additional wisdom as a peripheral, as something different? Because systems do not endure on funding alone. They endure on that communal legitimacy. Okay, so our roadmap today, here's how I would like to structure our time together today. First, I want to reframe sustainability not as funny issue, but as a structural survival question. And second, I will define what I mean by rediscovering additional wisdom, because it is important that we are precise about that. And third, I would walk us through examples from our mental health IPT model being implemented in Liberia, and maternal nutrition research that I did in the Gambia, just to show us how governance actually operates inside health system. Then we will zoom out and map this into the WHO building blocks framework. And finally, we'll discuss localization, not as decentralization or decentralization of services, but as structural reform. So let's make clear that this is not a cultural preservation argument. It is an institutional design argument. So when I say rediscovering additional wisdom, I'm not talking about nostalgia, and I'm not also suggesting that culture replaces science. If you all know me somehow, you know that I'm a person of science, and I will not propagate such ideology or concept to you. What I am suggesting is that community governance systems are the ones that already regulating behavior. So community governance systems should be intentionally integrated into formal health systems architecture. And there are three pillars that guide this idea. And the first pillar is that relational accountability. And the relational accountability I'm referring to is not accountability that exists in policy manuals, right? But accountability that is reinforced by just existing socially within the communities. That's that kind of accountability we are talking about. And the second pillar is equity by design. When I say equity by design, I mean that legitimacy or the community governance system is embedded from the very beginning of any intervention you are planning to carry out. The third and last pillar is the core ownership of that program, project, initiative of whatever you are planning to do in the community. Because when communities help govern system, they feel part of the system and protect the system because they see it as their own system. So they go on protecting the system. And that protection is what makes the system durable, makes the system last and survive funding cuts and the rest of it. Across societies, indigenous government is not abstract. It lives in everyday structures. The council of elders in our community, the chiefs, the town chiefs, the mother-in-law, the women group, all of those people carry moral authority in our communities. Like the women group regulate maternal norms, which we're going to talk about more or deepen in further down in the presentation today. The traditional midwives in our communities serve as trusted, and that one key word we will already talk about through all this presentation, trusted referral angles in our community. I don't know whether you know about Palawa Hut. Our Palawa Hut serve as a place for communion dialogue spaces, and these spaces sustain social order in our community. So these are not just symbolic rallies. And hear me, here's a system inside that I want to bring to your attention. Health systems do not enter empty spaces. So before we get the funding, before we design our programs, before we identify what geographical location we want to implement our programs, there are already existing governing structure within those areas. So if programs ignore that governance architecture within those communities, they will build friction into the existing governance structure or governance system. But when they align with that governance system, they will build legitimacy and subsequently acceptability of the program. And legitimacy is the one that sustains the uptake of whatever program or whatever service we take to these communities. The social system precedes health system. Every intervention, like we said earlier, interact with existing norms, right? These norms within our communities shape help-seeking behavior of community members. They also shape the ability for a community member to trust you and disclose what the problem is to you. They shape maternal practices, they shape stigma. So sustainability is not about funding. I don't even want to say it's not only about funding, it's not about funding at all or financing at all. It's more about alignment with the existing norms, existing governing structure within this community. So when system contradicts governance structure, resistance emerges. But when system integrates the governance structure, legitimacy deepens. Communal healing logic. So in many societies in Africa, in West Africa, in Liberia, healing practices here is collective. And I will let you know soon what that means. For instance, our IPT program that I talked about earlier, our IPT group therapy mirrors the communal identity of the structures we just talked about. We talk about the Palawa Hut. So participants sit in a round circle, for this section. These cycles symbolize equality. Everybody seems equal. Nobody is sitting behind a big desk or at the head of the big desk. So the fact that they sit in this cycle, they already feel like we are all equal and no one is better, no one is superior. They sit in this cycle, they are comfortable and they share their stories. So just by sharing their vulnerability, relational accountability is built. And this relational accountability strengthens the continuity through peer reinforcement. For instance, if there's a schedule for your section, because we all know our story, somebody is there to remind you to go for your session, just reinforcing whatsoever was agreed on during that session. Because our IPT session format mirrors that familiar communion dialogue patterns, we are having really good results of our program. So our IPT model demonstrates that when scientific intervention align with communion governance logic, skill becomes possible. Okay, the two I see. The two I see reflects this epistemic integration, where through one lens, we see science. With the science is the metrics, the protocol, epidemiology, monitoring and evaluation. And still through the other lens, we see that legitimacy, which are the moral authority, live norms, social reinforcement. So evidence without trust of the community will feel, and in the same manner, cultural or legitimacy of the governance structure within the community without measurement, the science aspect cannot be scaled. So so what is required is to obtain this is to be intentional about using both lenses in our program design and implementation. So I wanted to be a bit more interactive. I would like to hear from you all whether what I'm saying resonates with you in any way. You can leave comments in the chat. So in 2015, we conducted a study in the Gambia titled Food Taboos Among Pregnant Women in the Community of Mayok, the Gambia. The main question for our study was, why are pregnant women avoiding nutritionally beneficial food? But what emerged was maybe not misinformation that the mothers had. What we identified were informal regulatory institutions operating within this household of these pregnant women. Food taboo encoded perceived obstetric risks, particular fears around obstructed labor or delivery complications. They reinforce communal identity and that intergenerational continuity of this perceived obstetric risk. And importantly, enforcement was not abstract. The primary enforcer were the very mother-in-laws of these maternal taboos. The mother-in-laws were senior women within these extended household. The mother-in-law had the authority to monitor the compliance of these regulations, these taboo. So they carry moral authority, right? This is what we're talking. They regulated the dietary behavior of the pregnant women. So adherence was not based on ignorance. It was structured by the relational governance within these communities from one generation to the other generation. Now, here's the system implication. When nutritional programs approach the issue as knowledge deficit, we will say, oh, these people don't know better, these people don't know better. They experience resistance persistently. They kept experiencing resistance. But when the intervention engaged those governance actors, when they talk with the very mother-in-law that had the moral authority to monitor or regulate or reinforce the taboos, alignment improved. The mother-in-law was able to talk with the women to have some changes. So this slide is not about understanding that maternal health behavior are going within, are governed outside the community structure. It's clearly to show how these how much authority the mother-in-law specifically have within these different communities. So it's about understanding that maternal health behaviors are governed within social authority system. And if we ignore these systems, the technical guidance remains structurally weak. Okay, the WHO building block and the governance system within our communities. So the WHO building blocks framework has been foundational in global health system strengthening. It gives 6 structural components. It talks about leadership, it talks about workforce, it talks about service delivery, it talks about financing, information system, and access to essential medicine. But there is this analytical move that I want to make right now. Each of these building blocks operates within the social environment that we just talked about, right? And that social environment is structured by legitimacy. So the question is not whether the building blocks are technically sound. The question is whether these building blocks are socially embedded. This is the concern, whether these building blocks are socially embedded. So let me give an illustration right now. For instance, the first building block here is leadership. Leadership is not effective without legitimacy. So the authority within this community must be recognized for leadership to function. Like we said from the very beginning, if you ignore these authorities within the community, this component of leadership will not function well. The workforce performance depends not only on training, but on that relational belonging and the community trust. If you bring in the community, let's say total stranger, who does not understand the morals, the norms, the culture, the language of the community, definitely, it would be more than whether the person is qualified or whether the person is skilled or trained to implement the project or deliver the service. So service delivery is not simply the third building block, that's why it's not simply about access. It requires cultural safety. So the perception that care is socially appropriate, like I said from the beginning, is collective. People come together and care for each other. The financing mechanism of the building block, of the WHO building block, depend on that perceived ownership of the project, how the community perceive their involvement in the design and development of that project. So if the communities do not see themselves reflected in the system, contribution and compliance will be weakened. The information system, the collecting data and the rest of it, I rely on disclosure and trust. Community members have to trust you to be able to confide in you, to be able to tell you clearly what the problem is. Without trust, they will not tell you. They will just be not very clear with you. So reporting then becomes almost impossible or distorted because you're not going to get all the information from these community members. So what we begin to see, yes, this trust is not an optional variable. And when legitimacy is absent, each of the building block becomes technically present, but functionally fragile, just really weak. But when governance structures are embedded, each building block gets to be stabilized. So governance is not separate from the WHO framework. It actually mediates the whole idea of this WHO health system strengthening building blocks and framework. Next slide, please, Sandra.
Yes, I'll move to the next slide, Roseline. And we do have a question from Sarah Morrison in the chat, and she asks, what are the challenges you find in getting buy-in from community leaders and governance?
So the first thing I can answer now before we go to the next slide. As I said before, the community has to feel a part of the very design. Community members have to be invited, not as part-time, not as strangers. They have to be involved in the very design of what the problem is in their community. So once they are involved in identifying, for instance, you want to solve my problem and then you stay somewhere else and determine what my problem is and design program to come and solve my problem. You need to come to me. You need to ask me what the problem is. Once you come to me and ask me what the problem is, I trust that you are really willing to solve that problem. Then I'm able to become vulnerable to you, to trust you, to tell you all of what I'm facing. Like that, you will have enough information, and then we can co-design the problem together. There's one point I will soon discuss on, but let me just say it. So when you co-design the problem or the project with community members, it's easy for them to buy in. The next thing, you have to train them, capacitate them to take on leadership role. That's another thing. To take on leadership role, to participate in decision-making of that project. You will get their buy-in. I hope I answered that question adequately. The dual engine sustainability. Okay, I think your question was just in time. So sustainability is a dual engine system. One engine is technical rigor, like we talk about the financing, workforce, capacity, monitoring, evaluation, and the rest of it. The other engine is the social legitimacy, trust, governance, integration, and ownership. If other engine weakens, system destabilizes, right? So we must be intentional for balanced investment to achieve durability of our program. Basically, that's what this slide is saying. Localization, okay. So this is a topic that I'm passionate about. You hear me taking deep breath. Localization must move beyond phony decentralization or service decentralization or putting health facility or project in close proximity. We must move from the idea of decentralization. Localization is not the same as decentralization. Localization requires capacitating governance actor like the townships I just talked about, the mother-in-laws I just talked about. Those same mother-in-laws will be the trained traditional midwives. You know, just the governing structure within these communities, capacitating them or those who are beneficial or close to point of care to assume authority and participate in decision making. And not only that, this this power sharing must be institutionalized as well. So it goes from one project to the other, from one leadership to the other. And this is structural reform. We're not talking about just adapting. We need that structural reform. The operational principle for localization. So if we accept that governance, mediate system durability, then the question becomes operational for me. So you can tell me later what you think in the chat as well. What does this mean in practice? What are we saying? First, we have said already, co-design must begin from the very inception. You cannot design a project for a community without the community involvement. Community members, local people in a community must be part of solving their own problem and not as consulting or after the fact. It must be from the very beginning, right? And sometimes we design our project, we implement our project. We have this thing, if anybody know about, you tell me, validation workshop. We've implemented the project already. Then we call the community members and stakeholders to come and validate the project. You know, at the end of the project, we say from the very inception, the community has to be involved in the design of the project. We are advocating for shared problem definition at the very beginning because governance actors shape the non-compliance, like I just spoke about the mother-in-law reinforcing the taboo of maternal nutrition. So if you don't bring these people in, you already know what will happen. They need to come in before implementation. The second one is integration must be structural. We spoke about it already. We just kind of summing up that it must be structured. It must not be bit in pieces of adaptation. It's a system issue, and let's approach it from that lens. What we mean is that integrating the community health workers, the governing system in the community to do this, not as parallel actors, not as temporary partner, but as recognized component of that system architecture. The third one I want to talk about is the data system must be relationally anchored. We talked about what relational means earlier. So if the community members do not trust how data is collected, stored, or used, you're not going to get much out of them. Reporting becomes selective. They will tell you what they want to tell you and keep the rest of the problem. So supporting community or community trusted data processes strengthens disclosure and the integrity of your data. And the fourth one is leadership transition. I normally notice we start a project maybe in the last year of the project or in the last 6 months of the project, we start to plan transition. This, if you know you are going to transition to the Ministry of Health or to the local community, transition planning must start from the very early part of the project. So if the authority remains externally centered, system will collapse when the funding cycle closes. But if they are brought in, they know that this project will be transition to them. We want to think that the project will be sustainable, durable and sustainable. As we said, governance integration is not an option or is not a soft variable, is a must if you must obtain sustainability or durability of your project, because it directly shapes the uptake, the compliance, reporting, and accuracy. I think it's the last slide, Sandra.
Okay, I'll stop sharing. Bill has a good question. He says, when you go first to a palaver hut, how do you establish your legitimacy at that level?
When you go first to a palaver hut, how do you establish? So the legitimacy we spoke about repeatedly is you understanding the cultural norms of the community, you understanding the language they speak, you understand the leadership in the community. That's how you establish it. You need to know those and abide by those. That's how you establish the legitimacy. You got to know the cultural norms. You have to, if you can speak the language, you have to find a way to communicate by that language. You need to do, for instance, we say during our IPT section, the people sit in cycle. You cannot go and see the people sitting in cycle and say, because I'm the big boss, I can sit in cycle. You just are aligning yourself. So all of these matter, all of these governance structure matters. That's how you establish your legitimacy.
I think I just saw Sarah. Did you want to say something?
Not right now. I thought it after the slide.
Oh, Rose,
Okay.
sorry, I took it down too early. Maybe. Do you want me to reshare it? You have one more?
I need the
No problem.
answer. Yeah. And so we close, and we want to return to our central idea. Rediscovering additional wisdom is not preservation for nostalgia, right? It is, we are advocating for institutional design, structural makeover. And it is the recognition that governance already exists in every single community. Your policy that you develop at the Ministry of Health is not the only governance tools that you should use. You need to recognize that governance already exists in these different communities. And once you recognize that sustainable system, you will have a sustainable system or sustainable implementation model. Because when, as we said, when communities co-design and co-govern health system, legitimacy takes root. And when legitimacy takes root, systems are defended not because they are funded, but because they are owned by the community dwellers and by the community structure, to say. And systems that are owned are systems that endure. That is how health system lasts. Thank you.
So nice. Thank you, Roseline.
I
Yeah.
have one question, but I'll leave it for now. And Sarah, I think you said you had a question.
I did. Thank you so much, Roseline. That was an excellent presentation, and I totally agree with you. And I don't think things can really work and endure without that kind of a structure. My question was more on a very practical basis of when I was asking about challenges. Um, since you've been in your position, how what challenges have you faced when you meet together with the community leaders? Is it a factor of education about mental health, or is it that the problems are that they identify are things that are not in your goal parameters? Because you can't solve, maybe building a new school or a sanitation problem if you're going in for mental health. So what are the real day-to-day kinds of things tools that you use?
Thank you so much, Sarah, for that question. So exactly as you said, everywhere you go, let me talk about Liberia because it's where we are implementing. There is always a problem. And because also community members don't understand that projects you operate with a specific budget on a specific scope within a specific time. So they come to you with all of the problems that if you're doing mental health, if you do this, if you do the other, that would be better. They just don't understand. You need to take your time and make them understand that as an NGO, you cannot solve all of the problems. We need to look for local resources to tap in. With this collective effort, we can solve together most of the problem because you can't solve all of the problems, right? But you just need to be not sympathetic. I'm messing up the word. You just need to understand and put yourself in their shoe and be able to talk to them, let them know as a single project, you got budget that you work in, you got scope that you work under, you got time that you work. The resources just limited and just for that goal of that project. However, let's look within our locality and see what other resources that we all can put together collectively to make the community better.
Thank you.
You're welcome.
So I had a question that is something along these lines that I constantly struggle with. We come in with a model that has been chosen by people in international health, WHO, been tested widely in many countries around the world to do interpersonal psychotherapy with lay counselors and so forth. And it's something that has been shown to be effective, but then it doesn't mean that it automatically would be accepted culturally in a different context. And so, but then I do notice that many of the women in the women's mental health groups, they talk about going to their IPT group as opposed to talking, maybe a talking therapy group or a palaver group. They use the language that we are offering in the model. And I'm just wondering, what does that create for them? Do they embrace having an IPT group, or would it be better if they chose a different name for the same thing? Call it something that would be part of the local culture.
Yeah, so when they're talking to you, they will call IPT. Trust me, when they are talking among us, they have that money name. I can say it right now, but they have that money name that they always use.
Okay.
They say IPT to you because they know that's what you know and they want you to understand. But among themselves, they have a name. The name just slipping me. They use that name.
Okay. So we have to learn Bondi to have a real discussion here.
And the good thing about most of the facilitators, they speak English. So What I try my best to do is not to be technical at all. I listen to them very well and try to mimic, the way they speak.
Mhm.
If the tonation goes the way I'm able to, I would sound like that. If they use a certain word, not necessarily funny, right? But I just make it my business to pay attention to the way they will be able to understand me easily and accept me easily.
If no one else wants to ask a question, I'll keep asking questions.
Happy.
What's your perception of the community health worker relationship to the ministry clinics, let's say? Are they using the model that you're showing? Is the Ministry of Health, for instance, trying to use the local governance when they come in to do projects or to talk to the midwives, the traditional midwives, for example?
So the selective about it, to be honest, when I say the selective about it, I mean that they've chosen those people they put in a category of community health workers and including the TTMs, they use those as an anchor to leverage the community leadership.
Okay.
But what we are advocating is not that angle that you're using. We are advocating for them to directly engage with these people that have the real authority in the community. We are advocating for them to literally sit with them, talk with them, hear from them the very problem they face. Till now, data collection, data processing is still thing that people think around. You must have this data expert to do. Data expert to do. My thing is, why do you need an expert to collect data? You don't need that expert to collect data. If you had a feedback loop from the community, data collection would be very easy.
Hmm. Hmm.
So that's what we're talking.
So you're talking to the Ministry of Health as well to, you've got your community leaders on one side that you work with.
So no,
Too.
sorry, I didn't get that last part. Rushing the
I was
answer.
wondering if you can make the circle on the other side and try to influence them.
Definitely, we are definitely planning to do that, but making a change is a really strategic and gradual process. You must pull together all your pieces of evidence to lay on the table when you are talking to these policymakers. Have you piloted that idea? What was the result? Is it acceptable? You got to tell them the kind of details before they are convinced to make a change. We've made changes before, especially in maternal health, but for it to be a structural change, like I talk about data collection, they think this sophisticated data master should be the person to collect data, process data, and you can see that it hasn't worked and it will not work. They try to force it to work. It's so expensive and it's not yielding anything. So try to angle these strategies we are saying. Try to have a feedback loop of your implementation. And then you will get the data credible and in real time. You don't have to pay people to go to the field. After I started studying deep how community interact with services provided in the health system, I just see a lot of things that we're doing. We just waste a lot of money for nothing because people in a community, once you help them to understand the project, they can do that without paying all the money you pay every day.
There
There
we
we
go.
There we go. Good.
There we go. Roseline, that was a great presentation.
Thank you,
I've
Dad.
always believed that if you don't have community involvement, the program that you start in that community is just a gift. You package it, you bring it to them, and you say, here. And after the program is gone, the gift is gone, that's it. We'll go back to where they were. But I've never had it said to me in a very well structured presentation like you did. Thank you very much. I have a good example in local counties. A few years before I moved into Kolahun to establish care, USAID had a mega, a big project called Lofa County Rural Health Development Program. It lasted for 4 years to the tune of like $1 million a year. Everything was plentiful, vehicle up and down the road, drugs everywhere, free. After 4 years, the program ended, and so did everything end. It went all the way down. So by the time I got to Kolahun, there was nothing there.
Yep.
The vehicles were all on the side of the road, not repaired, not maintained or anything, because the community never took ownership of the program. And so it did not sustain. But that was a very good presentation. Thank you. And if we go and evolve the community from the beginning, from the planning stage,
Yeah.
they can have ownership of the program, and it will continue after you leave.
Yeah,
Thank you.
definitely. Thank you, Dad.
Great. Well, I don't see any last questions here. But thank you all for coming. It's wonderful of you to join us and hear from Roseline. And we will share this presentation as well. So it'll be available to access again if you'd like to review it. But thank you for joining us today. And thank you, Roseline, for such a great presentation.
Thank you, everyone.
Very needed, Rosalind. Thank you so much. I appreciate it.
Yeah.
Yeah.
Keep up the good work. Thank you.
Thank you all.